any signs of your area postrema syndrome, noted as your hiccups, nausea, or vomiting, and the patient also doesn't have any signs of acute myelitis. Another condition we could also consider, however unlikely, is neuroretinitis. This considers again the patient's symptoms. However, the patient does not fit the typical risk profile for your neuroretinitis. The patient also did not have any preceding flu-like illnesses or infections. The patient was also negative for a macular star, which we would have expected to be apparent about 2 to 3 weeks after the onset of the disease. For this patient, they were seen already 3 weeks after onset with still no macular star. There were also no noted herpetic lesions, nor disc pallor, or again, vascular changes on the retina. Now, other differentials for your optic neuritis might also involve conditions such as your infections involving TB, syphilis, or HSV. However, our patient was not sexually active, and again, with no history of infections. We could also consider toxicity from alcohol or medications. However, the patient denies any new medication use, and the patient's alcohol use was well regulated with branded beverages and not necessarily anything different from her regular consumption. Aside from these, we also have no history of trauma for this patient, nor any history of tumors. So it's worth noting that these things that I've mentioned are must be carefully ruled out in other cases of your optic neuropathy. Moving forwards,
So for the initial diagnostics done to rule out any infection or inflammation, CBC was requested, revealing normal results. CRP was elevated, indicating systemic inflammation, and ANA was positive, raising the suspicion for an autoimmune disease. Rheumatoid factor and RPR were non-reactive. Blood sugar and kidney function were within normal limits. Perimetry was done, revealing acceptable reliability parameters for both. A central 10-2 stimulus 5 full threshold strategy was requested on the left eye, which showed near absolute vision loss in the centrally, and then on the right showed no significant visual field defects. On OCT of the optic nerve, revealed fair signal strength, revealing thickening of the peripapillary RNFL layer superinasally, with relatively low CDR on the left eye. The OCT of the macula, which was done outside of MacPathMed, revealed unremarkable findings save for vitreomacular adhesion in both eyes with no surface wrinkling. So in this case, an MRI with contrast was requested, revealing no enhancing parenchymal lesion, no hemorrhages. There was, however, a suspicious thrombus in the left transverse sinus in the T1 weighted view, as shown on the image. Sorry, I played the other video. So this is the T2 weighted view. Unremarkable. And then, on the sagittal view, there's a filling defect in the superior sagittal sinus in the distal half. This is a T1 contrast weighted sequence. So at this point, our working impression was amended to include the compound myopic astigmatism for both eyes with vitreomacular adhesion, optic neuritis left eye, rule out demyelinating disorder, a superior sagittal sinus and left transverse sinus thrombosis, etiology to be determined, likely to be due to a hypercoagulable state, rule out autoimmune disease and residual Bell's palsy. So at this point, the problem list is as follows: the optic neuritis, the CVST, and the autoimmune disease consideration. So for the optic neuritis, we started the patient on pulse IV methylprednisolone for 3 days. Then the plan was to shift the patient to oral. There was also omeprazole given as gastric protectant. For the sinus thrombosis, the patient was promptly referred to the neurology service, and we wanted to confirm the presence of the sinus thrombosis, so further diagnostics were requested. then with the goal of treating with anticoagulants once confirmed, and then to work up etiology to prevent recurrence. And lastly, for the autoimmune etiology, the patient was hence referred to the Ruma service for workup of autoimmune etiology. So before we move on to what happened for our patient, we will discussing optic neuritis for short discussion. So optic neuritis is an inflammatory demyelinating optic neuropathy typically seen with multiple sclerosis, although it can be seen in other cases, and in fact it is most commonly idiopathic and may also present with as a result of infections. The typical patient profile is a patient 20 to 45 years of age, is female, and with the unilateral presentation of moderate to severe subacute vision loss with occasional central scotoma with pain with eye movement, which is actually the key symptom. And there's also reduced color vision, especially red saturation in the affected eye with RAPD, especially in unilateral or asymmetric cases. And about a third of these patients present with optic disc swelling because the other two-thirds may present with retrobulbar neuritis. So we can tell that from this table, our patient actually fits the typical patient profile. Then it's also prudent to differentiate typical optic neuritis from atypical. So when in terms of pain with eye movement, typical optic neuritis often presents with this. It's usually unilateral with mild or no optic disc swelling. Visual recovery for typical optic neuritis is usually more rapid and spontaneous, while for atypical cases can be poor or steroid dependent. MRI findings may be suggestive of demyelinating lesions or periventricular white matter hyperintensities, while atypical optic neuritis may have chiasmal or long segment or perineural involvement. The risk of MS development is moderate to high in patients with typical optic neuritis, and the steroid response is improved in typical cases. So, what red flags should we look out for in cases of atypical optic neuritis? So, when there's bilateral involvement, when there's no pain, or there's persistent pain, when there's poor visual recovery despite treatment, and with patients presenting with severe disc edema and with hemorrhages, and patients that are very young, less than 15 years old or older than 50, and those with recurrent attacks or those who are steroid dependent for treatment. So typically, for optic neuritis, the MRI of the brain and orbits with or without contrast helps primarily with ruling out other causes of optic disc swelling, as well as prognosticating our patients for developing MS. An OCT of the ONH in early optic neuritis may reveal peripapillary RNFL swelling. Later in the course, when the swelling has subsided, this may reveal thinning due to optic nerve atrophy. So a VEP may also be requested, which may reveal signs of demyelinating disease such as a delayed P100 latency with decreased amplitude, revealing decreased signal generation and neural transmission along the optic nerve. The other diagnostics to be done depends on the suspected cause, especially in cases of atypical optic neuritis. So the reason why we treat optic neuritis the way we treat it today is thanks to the optic neuritis treatment trial, which was done on 1992. Sorry. The purpose of this trial was to determine the natural history of optic neuritis, to evaluate the effect of steroids on visual recovery, and to quantify the risk of MS following optic neuritis. So, 457 patients aged 18 to 45 years old with no prior MS diagnosis were recruited. These patients presented with acute unilateral optic neuritis within 8 days of symptom onset. They were then subdivided into 3 treatment groups. One would be the IV steroid group, which was what we did for the patient, which is IV methylprednisolone for 3 days. Then the patient was shifted to oral prednisone for 11 days. The second group was treated only with steroids, oral steroids rather, for 14 days at 1 mg day. And then the placebo group received no treatment. So the key findings of the ONTT showed that visual recovery was faster by 1 to 2 weeks with IV steroids, but there was no difference in visual recovery at 6 months, meaning that while IV steroids may speed up recovery, it does not really improve visual outcomes. Most patients in the placebo group recovered vision on average in 6 to 8 weeks. Then they also found that after 15 years, greater than or equal to 92% of patients had a visual acuity of 20/40 or better in the affected eye. And thus, visual prognosis is excellent even in severe initial vision loss. In terms of recurrence, it was higher in the oral prednisone group only, with or group 2, with twice the recurrent risk. So, uh, simply we don't use oral prednisone in cases of optic neuritis. Uh, it's important to note that before this study, the patients with optic neuritis were frequently treated with oral prednisone only. In terms of developing multiple sclerosis, on 15-year follow-up, there was a 50% overall risk. However, this was further stratified if the patient had greater 1 MRI lesions or periventricular hyperintensities, which would increase the patient's risk to about 72% for developing MS. And then for color vision and field recovery, that was similar across all groups at 1 year. So, based on the findings of this study, we can therefore prognosticate patients that informing them that about 92% recover to greater than or 20/40 or better within 1 year. And the risk of MS development is higher if the MRI shows a white matter lesion. And then if the initial MRI at presentation was normal, then the risk is reduced to 25%. And in terms of recurrence rate, it may recur in the affected or fellow eye in 35% of cases and in 48% of patients that converted to MS. So in this patient, a confounder for our diagnosis would be the presence of a CVST or the sinus thrombosis. So the CVST is when there's a clot that forms in the superior, primarily in the superior sagittal sinus, but may also be in other sinuses of the brain, causing impaired venous drainage, increasing intracranial pressure, and causing neuroophthalmic symptoms. So this is a very rare condition with 3 to 4 cases per million, and the usual risk factors are patients that have OCP use, those are pregnant or otherwise with hypercoagulable states, patients that are dehydrated, and those with malignancies. So this is a reminder of the Virchow's triad for risk of hypercoagulability. For symptoms, patients may present with headaches, nausea, vomiting, seizures, and altered mental status. Signs that we may find on physical examination include bilateral papilledema, and it is rarely unilateral. There can be a cranial nerve 6 palsy, which is a nonspecific sign of increased ICP. There can be visual field obscuration, such as an enlarged blind spot, and there can be motor deficits if with infarction already. So the same workup was actually done for the patient. An MRI was done. You can also do an MRV or CT venography to visualize the thrombus and the filling defect. A coagulation panel is usually requested to detect the presence of thrombophilia. And then lumbar puncture can also confirm the presence of increased ICP. So the management of these patients are for primarily anticoagulation therapy with low molecular weight heparin, and then to manage all the other symptoms and address the underlying cause to prevent recurrence. So what happened in the patient's course? So on day 1 of admission, the patient was started on IV methylprednisolone at 1 gram per day. The patient at this point denied any headaches when patient had stable ocular symptoms. On day 2 of admission, the patient was given still on IV methylprednisolone, now noted with subjective improvement in vision, describing that her peripheral vision was starting to become clearer and was able to discern hand movements. The patient was also seen by Ruma service in the morning, and the following labs were requested. The final MRI reading done revealed the venous sinus thrombosis, so the patient was referred to neuroservice, and a cranial CTA was requested to confirm the presence of the CVST. Thus, a coagulation panel was also requested for the patient. Rheuma-wise, the tests returned normal, save for a vitamin D deficiency, so the patient was started on supplementation. So this is the CTA that was done. So here, there was no longer the presence of the left transverse sinus thrombosis, but the presence of the superior sagittal thrombus was confirmed. So for the bleeding parameters, the PTT of the patient was mildly decreased, which may imply mildly increased coagulability. On day 3, the patient was completed 3 days of IV methylprednisolone, and the patient was also started on anticoagulants. The patient also at this point denied any new ocular complaints and was ambulatory with no headache still. Day 4, the patient was shifted to oral prednisone at 35 milligrams in the AM, 30 mg in the PM. So this is the 1 mk day dose. Enoxaparin was then shifted to a oral apixaban, and the following results were released. So basically, there was no positive result. So connective tissue disease, AP, antiphospholipid antibody syndrome, and vasculitis was hence unlikely. So this is the appearance of the fundus photo post 3 days of IV steroids. So here we can notice that the optic disc had markedly less swelling, although there's still signs of nerve fiber layer thickening with an increased reflex on the fundus photo of the left eye. The other results returned negative as follows. There's also a negative an APAS panel, and this shows just the vitamin D deficiency found in the patient. There's also negative beta-2 glycoprotein and anti-cardiolipin antibodies. So day 5, the patient was stable, hence deemed fit for discharge, and patient was set for further workup as outpatient. Few days later, factor 5 Leiden results came out, which showed that the patient was also negative for any protein C or S abnormalities, which may preclude thrombus formation. So at this point, our diagnosis would be compound myopic astigmatism, both eyes, vitreomacular adhesion, both eyes, optic neuritis for the left eye, a superior sagittal sinus thrombosis, probably secondary to a hypercoagulable state, and Bell's palsy.
Now, to further discuss the case we've just presented, we're going to be comparing it to a similar case, this time of optic neuropathy, as a warning for cerebral venous sinus thrombosis. So this was a study created back in 2018. And so to discuss the case, this was a case as well of a 36-year-old female presenting with a history of visual impairment and pain on extraocular movement on the left eye for a 2-month history. So this patient was negative for headaches, diplopia, nausea, and vomiting, with a noted visual acuity of hand movements on the left eye, as well as papilledema on the left. This patient also had an unremarkable neurologic exam, CT scan, and biochemical examination. On MRV, however, this patient was noted with a filling defect in the left sigmoid sinus and superior sagittal sinus. Hence, this patient was diagnosed with CVST, despite unremarkable hypercoagulability studies. Now, similar to our patient, the patient in this study was also managed with anticoagulant therapy and IV methylprednisolone. By 2 weeks, however, in comparison to our patient, the patient in this study was noted with no improvement after 2 weeks. Hence, lumbar puncture was done with increased ICP noted, however, with unremarkable CSF findings. Hence, this patient underwent cerebral angiography revealing a dural AV fistula in the left lateral sinus. It was only after endovascular treatment that this patient saw clinical improvement. For this patient's prognosis, however, in the study, By the third month of follow-up, the patient was noted with improvement of their EOMs with no longer pain noted. However, vision was noted to be unrecoverable and was maintained at hand movements for the left eye. Now, what this study ultimately shows is the need for a comprehensive review of a patient's history and PE when evaluating for optic neuritis or optic neuropathy. These should be supported by various diagnostics, both ocular, systemic, and neurologic. And the determination of associated conditions should be exhaustive, with all potential causes and complications ruled out. Non-improvement to current therapy especially must prompt further re-evaluation. Thankfully for our patient, they were able to see clinical improvement after the course of IV steroids started, even before much of the anticoagulant was given to our patient. Now, to simply conclude our presentation, optic neuritis is a clinical entity involving, again, inflammation of the optic nerve. This, however, may be seen idiopathically or in the context of other distinct systemic and neurologic disorders. Some disorders we could consider would be vascular, endocrine, or even, again, specific neurologic disorders such as your multiple sclerosis or even neuromyelitis optica. While autoimmune is the most commonly suggested pathophysiology for your optic neuritis, the etiology of it still remains much unclear. And other causes could still include ear infections, post-vaccination syndromes, autoimmune diseases, toxins, and even drugs. With some occasions, optic neuritis being even observed as a manifestation of infection such as COVID. For management, this generally not just involves steroids and immunosuppressants, but also the control of contributory and associated conditions. While IV steroids are seen to improve visual outcomes based on our ONTT trial, plasmapheresis or IVIG could actually be considered if there's no vision improvement seen following steroid therapy, in which case co-management with IM and neuro actually becomes integral. Moving forwards, management for optic neuritis should be ultimately tailor-fit to the patient. This should be with respect to their entire clinical profile, as well as the myriad of coexisting conditions they may be facing, whether diagnosed during this admission or not. Some specific treatment modalities even may be beneficial for some cases of your optic neuritis, or even contraindicated in others. So of note, if a negative systemic workup is seen, you may consider a neurology referral to start disease-modifying therapies after your steroid treatment. IVIG, plasmapheresis, and even monoclonal antibodies, for instance, have actually been recommended for your optic neuritis. However, a case of multiple sclerosis may actually benefit from modalities instead of IFN beta, natalizumab, and fingolimod. However, it's worth noting that these medications could also worsen a case of neuromyelitis optica or even an associated NMO, again emphasizing the need for a comprehensive workup of the patient prior to starting these treatments. So again, we'd like to emphasize the need to involve a multidisciplinary team in complementing the patient's clinical profile, ruling out other potential conditions that may be affecting that clinical profile, as well as forming targeted management for our patient. And that basically concludes our presentation. Thank you for listening, doctors.
Thank you. Hello? Yeah. Yeah. Hello. Okay, thank you, Mike and Rich. Okay, do you have any questions for our consultants or residents?
Just a question. How long do you keep on giving the blood thinners in this case?
Actually, this case, hindi pa masyado sure about the hypercoagulable. We
Kaya
want to
nga.
read it out also. I actually wanted him to see also a hematologist. But with the neuro, kasi we haven't established. So what we want to do is do a repeat venography as outpatient na lang.
Okay.
So as to how long you'll be giving it, I'll have to check with neurology yung protocol nila as to we have to check kasi the repeat angiogram actually showed less thrombosis compared to the
Yeah.
initial MRI. So I think important for me first is to be able to really establish, is there really a hypercoagulability
Hypercoagulability.
that
Correct.
na parang precursor for this thrombosis?
Yeah, kasi parang I'm just wondering ano yung end goal mo for the ano 'di ba anticoagulant. Is there a target INR for this one? Parang how thin do you want the blood? Or standard dose lang tayo? Wala tayong hinahabol na number dito.
From what I know with neuro, wala silang it's standard dose lang.
So walang target na INR dito.
Yeah.
Okay.
And if you look
Yeah.
at her values na, it's actually not so bad.
Kaya
So
nga eh.
kaya I want to get the opinion of the hematologist
Okay.
para to be sure. I
So
got
if it turns out to be not a hypercoagulable disorder, kahit na nag-improve siya with the treatment, would you still continue the apixaban?
Yeah, I think I'll wait for the MRV result. If after that, parang kung nag-clear na, baka we can taper it off na. So no need for a long-term with the apixaban. Provided I co-manage with the neurologist also, but pending the venography.
Okay. All right, thank you. Very interesting case. Congratulations to our two first years. Good presentation.
Yeah. So this one lang, what I also wanted to, although it's parang rare normally. So normally you'd expect kasi talaga a bilateral, kung yung mga medyo severe, urgent cases na yung term, kanina you said, rich yung sa case mo doon. Just make sure lang when you say the term papal edema, di ba? When do we use that term again?
When we have a case of a patient with increased intracranial pressure po, doc. So generally this could involve other neurologic signs such as your headache, vomiting, and we could also see edema of your disc as well.
So it involves also dapat both eyes, di ba, with disc edema. So bilateral, and then if you're associating it with an increased ICP. But in our case, this is a unilateral, no? Although there are cases talaga na unilateral lang, but normally if you read up cases, they would present bilateral, tapos andun yung mga typical signs of increased ICP. No, in this patient, one eye lang. So kaya when we saw this the result, diba? I told you to also watch out for the other eye. Kasi nga, pwedeng maging bilateral, no? But so far, this patient, medyo mild naman, para naging incidental finding siya. So what's just interesting is, it presents like, you would think as a typical optic neuritis, no? She has the typical features, no? Typical young female, with eye pain, sudden blurring of vision, no? But then we see here that there's a lot of confounding factors, no? So is it an autoimmune problem? Is it due to a hypercoagulable connective tissue disorder? And then here comes the other diagnosis na pampagulo din, the thrombosis. So it's important, like what you mentioned, the multi-specialty approach, no? That you have to rule out everything. So, how you approach this patient. Any other questions?
Ay, question lang. If thrombosis talaga ang ano natin, would there be any retinal vein, parang tortuosity that we can expect?
Possible, Doc. Although this patient, well, hindi kami nagpa-angiogram pa, pero
But looking at the photo, parang hindi siya masyado, di ba?
parang wala, Doc. And
Oo.
and this patient nga also has no parang mga predisposing, parang very healthy. So you wouldn't, parang unlikely.
Yeah. Okay. Sige. I was just thinking kasi kung thrombosis ang iisip natin of the bigger, the smaller vessel should have some also. But yeah, wala. Okay. Thank
For
you.
for a young patient also, like sila Rich mentioned, then you also you check for like yung mga use of pills, no, yung mga other things that can be possible din sa history, which they also ask naman. So wala din. What else pa? Any other questions?
Doc, I have a question. This is Trisha.
Yes, Krisha.
My question is, when do you order, parang once you've started the anticoagulants, when do you expect it to show or the change to show in repeat imaging? So like when do you order repeat imaging?
Which one? The venography?
Yes, doc.
Well, ideally talaga this patient, if you were to order firsthand, kasi this one kasi it presented with unilateral disc swelling. So we usually diba, request MRI, brain with contrast. If you think naman obvious na may disc edema, no need na for the orbit, no? Diba sometimes if it's retrobulbar, MRI, brain orbit, no? But if you have a patient presenting na with bilateral disc edema, always include your venography. No? So MRI brain with MRV. In this case, so we did an MRI brain, and then when we were working up the patient, they were thinking of possible. I actually added pala MRA pala in this patient, tama ba, Rich? So incidental finding, no? But
Yes, Doc.
ideally, kung bilateral, do a venography always, regardless of the age or what, laging venography. And then, when you repeat yung question mo, no, so if you're on, blood thinners or what, this one kasi nag-angiography sila, inpatient, the Ruma requested for a CT angio naman. And then, the neuro wanted a venography. So, just to neutralize ang dami ng tests ng patient, since na-detect na on the angiography, I said, we can medyo defer na the venography. So, usually, we can, since nag-start na ng treatment, minimum nila is about 2 to 4 weeks yung next follow-up, no? Ideally, like this patient that we're still monitoring, earliest that I can repeat it is 2 to 4 weeks from the first one.
Thank you, doc.
Okay. Any more questions? Okay, so if we're, yeah.
Yeah, go ahead. Go ahead.
I'm just gonna if
Sige lang, summarize.
Okay. Okay, so yun, I just asked the medyo complicated for our first year residents, but at least kasi they saw this patient, so that it's important lang for parang take home message also for them. So not all your typical optic neuritis will present typically, no. So even though this is the typical profile, no, yung female, young, so may mga surprises, no. And it's also important how it's important in neuro-ophthalmology kasi sometimes it can be a really life-threatening condition that minsan ikaw yung unang makakita dun sa patient, no? It's just that it just so happened with this patient, hindi ganun ka-toxic, but it can also happen that it might be talagang increased ICP, bilateral, so medyo mas aggressive, no? So, just make sure that you remember cases like this. We have a lot of ophthalmic emergencies then in ophthalmology. So, thank you, Rich and Mike, for your report. That's it, Doc.
All right. Thank you very much, Rich and Mike and Jamie, no, for a very interesting case presentation today. So please stay on. We have a presentation from Docuty. Maybe Adele, we can send them in for a quick presentation lang. Thank you, everyone. Adele?
Doc, yes po.
Yeah, we can send them in. Thank you.
Ma'am Joyce, you can share your slides na po.
Hello?
Hi, ma'am. We can hear you po.
Okay. Hello, doctors. Good afternoon. I am Joyce Diliaco from Docuity Philippines and in working partnership with Soleil Pharma. So, Soleil Pharma po is a European company from Latvia. And one product from our portfolio is Pocumax Vision Formula, doctors, that is intended for your specialization. Before we play the video po, I would like to thank Dr. Sherman Valero for connecting us with the group. Thank you po, Doctor. And allow us to play a 1-minute video for Pocumax Vision Formula. It's an AREDS 2 eye formula, Doctor, for AMD. Thank you.
I think you're muted po, ma'am.
Ayan, Doctor, just to add, Dr. Pocumax Vision Formula is a dietary supplement designed to support eye health, particularly in individuals with age-related macular degeneration. Its formulation is based on age-related eye disease study and includes key ingredients such as lutein, zeaxanthin, vitamins A, C, and E, and taurine. Potential benefits of Pocumax Vision Formula for AMD doctors is its antioxidant support, vitamin C and E, along with zinc, act as antioxidants that helps protect eye cells from oxidative stress, a factor contributing to AMD progression. Also, doctor, its macular pigment enhancement, lutein and zeaxanthin are carotenoids that accumulate in the macula, filtering harmful blue light and potentially slowing AMD progression. Also, it has a photoreceptor protection. Taurine is included to support the health of photoreceptors and may aid in preventing degenerative changes associated with AMD. So, doctors, Pocumax Vision Formula is available in Mercury outlets, specifically sa People Support. It's only 589 once a day in boxes of 30. So parang 19.63 lang po siya per capsule. Thank you, Doctor, for this partnership, and I hope you will include me in your CME activities. And Doctor, let's bring best care to our patients with Pocumax Vision Formula for your AMD patients. Thank you, Doctor, and looking forward in covering and engaging with you sa mga clinics ninyo. Salamat po. Have a nice weekend po. Thank you. That's it for us.
Thank you very much.
Thank you.
Thank you, Dr. Valero.
Well, thank you everyone. Have a good afternoon, and please wish Kaya good luck. The orals will be next week, I think. The written exams will be next week, no? So, siya lang yung magte-take na exam sa atin. So, let's wish him all the luck. Thank you very much, everyone. Have a great weekend. Thank you.